Good afternoon, ladies and gentlemen. Welcome to the scientific program session for arthroscopic and distal radius fracture. My name is Jeob Lee from South Korea.
My name is Philippe Liverneaux from France.
Jeff Ecker from Australia.
Yeah. We have 7 talks in a 1-hour session. I'd like to invite the first speaker, who is Jung Jae-wook. He will be presented the title, Prognostic Factors Affecting Clinical Outcome of Arthroscopic Assisted Reduction and Volar Plating through Pronator Quadratus Preservation for Intra-articular distal radius fracture. Dr. Jung, please.
Good afternoon. Thank you for introduction, Chairman. Distal radius fracture is most common upper extremity fracture, and open reduction with volar plating has been widely used. But previous study presented that 33% of patients had an articular step of over 1 millimeter, and another study reported that 70% of patients need refixation after conventional ORF. In recent studies, PQ preservation for volar plating provide better functional outcomes. We try to evaluate the effectiveness of our technique and try to assess prognostic factors that affect the functional outcomes. Our study was retrospective in a single center. Subjects were patients underwent our technique for intra-articular distal radius fractures and followed up until minimum 1 year after surgery. Exclusion criteria were extra-articular distal radius fracture, multiple trauma, cognitive impairment, etc. Finally, a total of 54 patients were enrolled. 31 females and 23 males with average age of 51 years were included. There were 7 C1 fractures, 27 C2 fractures, 20 C3 fractures. Surgery was performed by volar approach and PQ muscle was exposed. Some muscular plate sliding and proximal screw fixation were proceeded. After that, we set the arthroscope with wrist tower and then reduced articular fragments by the probe. Thereafter, temporary fixation of K-wire were proceeded. In arthroscopic video, debris mound and hematoma evacuation were proceeded, and then reduction of articular fragment and temporary fixation of K-wire were proceeded. Finally, distal locking screws fixation were performed. Let me show 2 cases. 31-year-old man with distal radius fracture by slip down. It was C1 AO type C3. Volar plating presetting with PQ preservation was performed, and then reduction of articular fragments with arthroscopic guidance and temporary fixation of K-wire were proceeded. Thereafter, distal locking screws were fixed. This is 1 year follow-up X-ray. Second case, that 50-year-old woman with distal radius fracture by slip down. It was also AO type C3. Volar plate presetting with PQ preservation, and then reduction of articular fragments were performed. Thereafter, distal locking screws were fixed. There was no arthritic change on X-ray at 1 year after surgery, and Mayo risk score was 19.5. Clinical outcome parameters were as follows, and we evaluate prognosis by modified Mayo score. Radiologic parameters were measured by X-ray and CT imaging, and we measured the radiologic parameter like this. Statistical analysis were as follows. At 1 year after surgery, clinical outcomes showed reliable scores. Radiologic parameters between injured and uninjured wrist had no significant difference at 1 year after surgery. There were no complications like non-union, CRPS, etc. There were 10 excellent, 22 good, 14 fair, 8 poor by modified Mayo score. We divided into 2 groups to assess prognostic factors. Excellent and good prognosis were to be satisfactory group, and fair and poor prognosis were to be unsatisfactory group. As a result of comparing the 2 groups, female intra-articular comminution, radiologic parameters with red colors were statistically different between 2 groups. We entered those variables into a logistic regression, and female intra-articular comminution, difference of palmar articular tilt were resulted in prognostic factors of unsatisfactory group. Especially, difference of a palmar articular tilt compared to uninjured wrist that is over 20.1 degrees resulted in poor prognostic factor. Limitations of this study were small sample size and retrospective and no comparison with conventional technique. We divided into two groups only based on modified Mayer score, also limitation, and effect of our technique still unknown. Our technique showed reliable prognosis, but female intra-articular comminution difference of palmar tilt compared to uninjured wrist over 20.1 degrees were considered as poor prognostic factors. Thank you for your attention.
Thank you, Dr. Jang. Is there any questions or comments from the audience?
I have a question for you. Yes, it's preserving the prenatal quadratus is a very good idea indeed. My question is, don't you think you can make your skin incision smaller?
You mean PQ preservation makes small incision?
Yes. Why don't you make a skin incision smaller, like a minimally invasive incision? Because it's not necessary to make a so large incision. Don't you think it's possible to make it smaller?
Well, maybe I think we can small incision than conventional technique.
Okay.
Any other questions? Question there? No? Yeah. So in essence, what you're saying is the greater the comminution, the greater the displacement, the worse the outcome. Yes?
Pardon?
It's okay, fine. It's all right. Yeah.
I have one question. Based from your results, that it seems like the failure of the restoring radiologic parameters, like length of the radius, inclination, may be more important than the reduction of the intra-articular joint fragments. What do you think about that?
I think so, but our result in radiologic parameter at 1 year after surgery, we have no difference between injured and uninjured wrist. So maybe this technique can make good radiology parameters.
Thank you very much. Now I call the next speaker, Dr. Siu Cheong from Hong Kong, who will present arthroscopic assisted reduction versus fluoroscopic reduction in treatment for AO type C intra-articular distal radius fracture.
Thank you, Chairman, for your kind introductions. So, functional outcome of the distal radius fracture is affected by many factors, with the articular stepping and the intra-articular gapping being the most important. And this was illustrated by Jesse Witter paper and the Trumbull's paper. But why? So Gabby has performed a arthroscopy in 20 patients at the time of implant removal. What he found is there is fibrous tissue formations from the previous fracture gap to the scapholunate, intracranial ligament, and the joint capsule, limiting the range of motions and then affect the functional outcome. So the rationale of our study to use the arthroscopy is to minimize the fracture stepping and gap, so as to decrease the intra-articular fibrosis formations and improve the functional outcomes. And our study tries to compare the radiological and functional outcomes in the conventional fluoroscopic group with the arthroscopic group in the treatment of AO type C distal radius fracture. From April 2016 to March 2018, we have performed a retrospective case match study. We allocated patients in two groups with age, gender, fracture type, and hand dominance being matched. For patients under the age of 18, patients cannot attend the physiotherapy training or for a period less than 3 months excluded from our study. So all the procedures are done by specialist level surgeons. the operation is performed under general anesthesia, and the fracture is approached through the roller handling approach. And fracture is fixed with a distal radius locking plate, plus or minus dorsal plating, depends on the fracture pattern and the surgeon preference. For group, only the arthroscopy is used for the fracture reductions, whereas in arthroscopic group, we use the wrist arthroscopy to directly visualize the fracture patterns and directly under the visions to reduce the fracture fragment and definite fixation with a distal radius locking plate. Also, in arthroscopic group, you have a chance to assess the radiocarpal and the midcarpal joint to look for any other intra-articular soft tissue injury as well. After the operations, except for those patients who have received treatment for the intra-articular soft tissue injury, all the patients have the same rehabilitation protocol. So we have recruited 24 patients in our group and allocated into 2 groups. FHH is 57.3 years old, and the follow-up period of time is around 12.5 months in average. And there's no significant difference between 2 groups regarding to the confining factors. So we have 6C1, 7C2, and 11C3 in our studies. And in the arthroscopic group, we have the 5 TFCC, 3 SL, and 1 LT intraocular segment tear, which were found and treated accordingly. So for the radiographic evaluations, the arthroscopic group has a statistically significant improvement in the articular stepping and gapping, and all 4 radiological parameters with the lower tilt and ulnar variance being statistically significant. About the functional outcomes, arthroscopic group also has a better result in terms of all 4 range of motions and grip strength recovery. For the modified Melville scores, the arthroscopic group has a better result with a 2 excellent, 2 good, 8 satisfactory, whereas in the arthroscopic group, we have only 1 good, 8 satisfactory, and 3 poor outcomes. And the mean modified risk scores is also better in the arthroscopic group. And there's no complications in our patients. So we have proved that the risk arthroscopic assisted reductions is useful in reducing the articular stepping and gapping so as to improve the functional outcomes. Also, we have the second chance to assess the intra-articular soft tissue injury and treat it accordingly with minimal soft tissue disruption. However, wrist arthroscopy is a technical demand procedure in acute distal radius fracture, and this paper showed that it is not worthy to use arthroscopy because the result is the same. But when we look into our study group and with the previous paper, we found that we have a younger age group with better radiological restorations, so that probably it may explain why we have a better range of motions and better functional outcome in our group. And also, there's a recent meta-analysis support our observations. But the limitation of our study is we are only the retrospective study with small sample size, with minimum follow-up time, short follow-up time. So therefore, prospective studies with longer follow-up is required. So in summary, we found that wrist arthroscopy is an important adjunct in the distal radius fracture management, and it allows excellent visualization of the joint surface for restorations and precise fracture fixations, precise fracture reductions, and evaluations and treatment of the intra-articular soft tissue injuries at the same time. Thank you very much.
Thank you. Thank you very much. Any question from the audience? Yes, please.
Thanks for your presentation. So I was interested to see that in the arthroscopic group, you had better restoration of extra-articular indices, including ulnar variance. So one question is, why do you think that is the case? And the second thing is, could there be a bias that the more difficult extra-articular displacements were done fluoroscopically, and the more difficult intra-articular ones were done arthroscopically? Because it's a retrospective study, right?
Yep. I agree with some of the observations you have found, but what we have done in our arthroscopic group is we use the PSET technique that described by Dr. Aby, that he tried to reduce the roller fragment first and fix it to the roller plate so as to act as a platform for you to reconstruct all the other articular surface. So I think it is the reason why we have a better restorations of all the parameters in the radiological parameters.
How much difference was there in ulnar variance? I missed your numbers, but between the two groups?
I think in the interest of time, we'll have to move on. And Jeffrey, you can discuss
maybe
this outside and
discuss
sort the problem out and resolve the issues. Okay, but
Okay.
thank you. That's a fabulous talk looking at different variables. In the future, we'll get some answers. Thank you.
Thank you.
I'd like to ask Nicholas Smith from Australia to help us work out how to arthroscopically reduce complex fractures and make it easier. Thank you.
Thanks, Jeff. So we're all familiar with this, and I'm probably not having to convince anybody here of the benefits. Just some thanks to the pioneer, Dr. Abe. Thanks to Mark Ross for taking that photo for me. And also to Paco Del Piñal, who I think has taught us all a lot about this problem and how to best treat it. Some of his key lessons that I have found very useful. One is dry arthroscopy. I think this is very important. The most important thing is you don't get swelling, and it takes the pressure off you in terms of the time, so you can relax a little bit. The important message is to get an accurate articular reduction as well as extra-articular parameters, and to minimise, as we just saw, the articular steps and gaps which can lead to fibrous bands leading to decreased wrist motion without really adding any morbidity, especially if you're using dry arthroscopy. Here's something from Paco's atlas, and it demonstrates, firstly on the left, the reduction of the palmar fragments onto the plate and then holding them with K-wires through K-wire holes, subsequently reducing the dorsal fragments under arthroscopic control, and then finally definitive fixation. The problem can arise when the K-wires toggle or wobble in the holes. Secondarily, adding the definitive fixation whilst in traction is really a two-surgeon procedure. It's quite complicated, difficult. You're never quite sure what's happening with the drill, whether there's a nerve or a tendon being wrapped around the drill while everybody's looking at the video monitor. So it's probably only for very experienced expert surgeons. The purpose of this system is to try and make it more easy, really. This is an illustration of the system. You can see there's K-wire guides which hold the K-wires to the plate, and the rest of the system is cannulated to make sure we don't lose reduction after we've achieved it. So the concepts are increased stability between the temporary K-wires and the plate, and easier fixation during arthroscopy, also not to lose the reduction once we've achieved it arthroscopically and we're changing to definite fixation. The components of the system are a special plate, K-wire guides which insert into the locking holes, and of course the K-wires. A new plate was designed with this in mind. Mark Ross introduced the idea of having two styloid screws to help with stability, but also during the procedure. Subchondral support of the screws and non-convergent screw vectors so that the guides don't butt on each other. So here's the plate with the guides, K-wire, and the instrument for removing the guides and measuring the screw or the peg length. So the steps are, firstly, achieving reduction of the volar fragments under direct vision, interdigitating the fragments. Then we apply the plate, we localise it very carefully, then fix it proximally with the screws. We can then insert K-wires into the volar fragments, and you can see we only introduce the K-wires maybe a centimetre, only fixing the volar fragments. This is very important. We wish to leave the central fragments and the dorsal fragments still mobile so that we can reduce them arthroscopically. We go into traction, I use vertical traction, and you can see the K-wires protruding and they're easily accessed. The guides help protect the soft tissues so that when you spin the K-wires, you don't wrap tendons or nerves around the wires. We go to the arthroscopy, we look at the articular surface, reduce it via whatever method is necessary. Here it's just thumb traction, but the point is that you can be concentrating on the screen. The surgeon is looking at the screen, controlling the reduction, and not having to worry about what's going on with the K-wires while the assistant advances the wires and secures the reduction. Then it's a matter of taking the arm out of traction, measuring the screw length from the K-wire, removing the guide, over-drilling the wire with a cannulated drill, and then inserting the cannulated pegs. And so there's much less risk of losing your reduction whilst going from the provisional to the definite fixation. The system does work on any of the 2.4 millimetre plates, and here's a very distal fracture where we needed to use a volar rim plate. The same guides and wires can be used, and we were able to achieve a very satisfactory reduction. So it's a technique presentation. There's no statistics. I hope you find the technique helpful if you're into that sort of thing. Thank you very much.
Thank you, Nick. Are there any questions from the floor? I have one on my left, far away.
I have a question for you, Nick.
Philippe.
So, it's not the question that you asked me to ask. Yes, your technique is very clever. You try to make it simple, but you still use a large incision and you don't respect the pronator. So do you think you can use this technique with a minimally invasive incision?
Well, I just used the larger approach so you could see what I was doing for the purposes of the presentation, Philippe.
Nicholas, I have just one question to you.
Thank you.
Sometimes I feel that it's very difficult to restore the volar tilt of the volar lunate facet for the first fixation. Do you have any tips?
What I do is I interdigitate the fragments, meaning line them up very carefully, and then apply the plate. And then once the plate's securely fixed with screws, then I push with manual pressure everything onto the plate, and thereby pushing the volar fragments onto the plate, and then it's easy to put the KYs in and fix it onto the plate in that reduced position.
Nick, what do you do with the severely comminuted one that's, Humpty Dumpty? It's a little bit difficult. Do you just hang it up in traction, then arthroscopically reduce it, convert it into a two-part, and then reduce it? How do you tackle the really ugly one?
Again, the same way. When I used to use plates everywhere, volar and dorsal plates, I used to start on the volar side because the volar side is where there's usually less comminution and you can usually start getting somewhere. So getting fragments lined up, and then, so I would do the same technique. And you build stability as you achieve reduction and then achieve some stability in what you have, then it's easier to put the puzzle back together.
Well, thank you,
And
Nick.
I think it's still possible arthroscopically, even in those exploded fractures.
Me too. Yes, question?
Do you have any experience from a delayed fixation of these fractures, like 2 weeks plus? Do you have to use bone graft for die punch fractures when you reduce them, when there is a big cavity underneath?
Yes, I have, and taking it out to the ultimate degree, even if you're doing an intra-articular osteotomy, I think it's still possible to use this. I mean, it's the same technique, but you just add the osteotomy. And usually mobilizing the fragments, you can just do that with a Freya dissector or a dental hook or something. I don't use bone graft, even if there's quite a large defect. I think the plate's enough now, the fixation's adequate. I definitely don't like bone graft substitutes.
Thank you.
Thank you.
Nicholas. Now we move on to the next paper. The title is Operative Treatment of Intra-Articular Distal Radius Fractures with versus Without Arthroscopy, Radar Trial, which will be presented by Caroline Selles from Netherlands, please.
Thank you very much. I'd like to present the results of our RADAR trial. As we all know, the distal radius fracture is a very common fracture, and there's been an increase in volar plate fixation because this leads to immediate mobilization and a quicker resume of function. But some of these patients who've undergone operative treatment, they continue to have a stiff and painful wrist. So that's where arthroscopy comes in, and it gives us these possible advantages where we can assess our quality of reduction, and we can remove hematoma and debris. We can also assess and, when necessary, treat associated soft tissue injuries. So that's why we set up this study where we aimed to determine the difference in functional outcome, which we assess with the PRWE score in patients with only plate fixation or an additional arthroscopy. And we hypothesized that in the patients with additional arthroscopy where we removed the hematoma and debris, that they would have better functional outcomes than those treated non-arthroscopically. So we conducted a multi-center randomized trial in 2 university hospitals and 1 teaching hospital. It was a superiority design, and we randomized between additional or no additional arthroscopy after the plate fixation. We included adult patients with distal radius, intra-articular distal radius fractures, which had an unacceptable closed reduction requiring plate fixation. And we adhered to the national guidelines for acceptable reduction. We excluded patients with a prior impaired wrist function, those with open distal radius fractures, multi-trauma patients, or patients who had other injuries of the ipsilateral extremity. As previously mentioned, our primary outcome was the patient-rated wrist evaluation score at 3 months, and our secondary outcomes were the DASH score, pain, range of motion, and grip strength, and the complications. We based our sample size on the PRWE at 3 months, and with a power of 80%, we needed 23 patients per group. We accounted for 5% loss to follow-up, and we needed 50 patients for this study. So we included 50 patients, 25 in each arm. Here you see the baseline characteristics where it's predominantly female patients in the end of the 50s, begin 60-year-old. And actually the only difference, quite obviously, is that the patients treated with additional arthroscopy had a half-hour longer operation duration. So when we look at our arthroscopic findings, we only performed arthroscopy in 22 patients. This was because in 3 patients, the dorsal capsule was already opened, and we didn't perform arthroscopy for these. And we see that all of these patients had a hematoma, intra-articular hematoma. Half of them had free bodies. And when we look at our quality of reduction, we still see that some of our patients had a step or a gap larger than 2 millimeters. This was left untreated. Other arthroscopic findings were predominantly TFCC injuries in almost 90% of our patients, followed by damage to our lunate fossa and the scaphoid fossa, and half of the patients had at least an LT injury or an SL injury. Here to the left, we see the assessment of our gap and our step, and here we see that this patient had a step of 2 millimeters. And on the right, we assess our soft ligament injuries, and here you see that this patient had a complete SL grade 4 injury. When we look at our outcome measures, the PRWE score, we see that these are similar at 3 weeks. At 6 weeks, they're also similar. At 3 months, our primary outcome, the arthroscopic group actually has a statistically worse outcome. However, when we continue our follow-up from 6 months onwards to a year, we see that the PRWE score is similar between both groups, with that 1-year follow-up actually excellent PRWE score of 7 for both groups. Our other outcomes, we see that the VAS score, so our pain score, was somewhat better for the arthroscopically treated patients. In range of motion, we saw no difference between the groups, and there was a slightly better grip strength for the group in which no arthroscopy was performed. Complications in both groups were equal, 7 in each group, where the most common complication was the implant-related complaints, so due to the plate which had given the pain in the wrist, for which we removed the plate. followed by 2 superficial wound infection treated with antibiotics, 1 FPL rupture, and 1 ECU tendinitis. So to conclude, we'd like to say that arthroscopically removal of hematoma and debris after distal radius fracture fixation does not improve functional outcomes, and we'd like to stress that there's no distal radius fracture without associated injury. Thank you very much.
Thank you. Thank you. Although the sample size is not that big, it's a high-quality prospective randomized study, which will be very nice. Is there any comments or questions from the audience? Yes, please.
From France. Thank you for this study. I have one question. Did you compare the different type of fracture between the 2 groups? I mean, did you have the same number of like fracture AO type B and C between the 2 groups? Because it can make a big difference.
They were all intra-articular fractures.
Thank you very much. You tell the truth. I like this. My question is, what kind of incision do you use for the plate? Do you preserve the pronator?
No.
Why? This poor pronator, everybody wants to kill him.
We don't see additional value.
If I operate you, I will make you an incision that big, and you will see the difference.
How's my functional outcome?
Caroline,
Yeah.
now that you've done this study, will you put an arthroscope into your next distal radius fracture?
To purely remove the hematoma and the free bodies, no.
So you see no place for arthroscopy in distal radius?
I do, but...
Why?
I think it's also part of what the surgeon prefers.
Sorry?
The surgeon preference in your reduction maybe, or your fixation, or the additional lesions. But I think what's very interesting in this study is that these lesions weren't treated, and they had good functional outcomes as well. So I think you need to be critical as to when you use your arthroscopy and when you can.
That's why I asked you whether you put a scope in your next.
No, not in all of them.
Not all of them. Thank you.
Thank you very much. Now I call the next speaker, Dr. Arora, who is the world champion of prospective randomized trials. And it's very important, I believe everything you say. And you will talk about the influence of arthroscopy, arthrotomy, and conventional fluoroscopy in palmar locking plate fixation of intra-articular unstable distal radius fractures.
Thank you, Philip. I'm not the master, but actually I could go back because everything I wanted to say is already said. So if you look in the literature, there's only one level 1 study which is compromising or comparing actually a roller locking plate with additional arthroscopy, yes or no, and this is the only one level 1 study. And in this case, and also in the case before, they don't assess the arthrotomy. So we said, okay, whenever we come up and say that we love to do the arthroscopy, all the partners who are against arthroscopy, they say, okay, why you use the arthroscopy? Because we make a dorsal arthrotomy and we see enough what we want to see, so there's no need for arthroscopy. So we wanted to say, okay, we should assess also the arthrotomy group. That's why we compared 3 groups, fluoroscopy, arthroscopy, and arthrotomy from the dorsal side. And we only used the palmar locking plate. We already did some kind of reduction, put the plate on the shaft, no screws distally, and then after primary fixation and reduction, we scoped them, and we have still time for fine-tuning for the joint in the arthroscopy group. So there were the inclusion criteria. They were all unstable intra-articular fractures, type B and C, according to the AO. And these are already the results. Patient demographics, you see there is no difference between the groups. This is the X-ray result. We did a we did a CT scan at 3 months, just to evaluate our steps and gaps after the reduction in all these 3 groups. So these were the pre-operative radiological measurements. And then at mean 12 months follow-up, we have this kind of functional results. The only statistical result was that in the arthrotomy group, the flexion was the worst. which is actually very, very logical, because if you do the arthrotomy from the dorsal side, and even we did not suture the joint capsule back, we left it open, the group of the arthrotomy had the worst flexion. The DASH scores were almost same, also the PRWE. And if we go and look for the steps at the 3-month CT scan, they were also not statistically significant. Surgical time, you can see here, the arthrotomy time was much longer, 46 minutes, including to the arthroscopy and fluoroscopy. So if you look to the clinical results at 12 months, as I already said, the worst clinical result was the flexion in the arthrotomy group. At 12 months, there were no difference in pain, Gibbs strength, DASH score. But the PRWE score was better in the arthroscopy group. At 3 months, no significant differences between the 3 groups. Of course, at the CT scan, there were most intra-articular steps and gaps, mostly were located at the lunate facet. We did a small series here. This was just for us, just to have some gain our knowledge. We just removed the whole carpal bones, and then we did this arthrotomy and did a step cut and made a joint impression for more than 2 millimeters. And then we did a fluoroscopy. And afterwards, we put in the carpal bones, and what we saw, as soon as the lunate is here, you don't see the die punch fragment on the dorsal side on the fluoroscopy. So that gave us actually, because of this small series, we started to do the arthroscopy. Arthrotomy group, yes, there were second most last intra-articular steps, because we believe that the extrinsic ligament, the radiolunar-tricutor ligament, is the end of our line. We don't want to go more ulnarly. So if you do the arthrotomy, we don't want to cut the extrinsic ligaments. And that's why you don't see the joint impression on the lunate facet, either on the volar side, not on the dorsal side. Arthroscopy, as you can imagine, the best radiological results, because we did every step and gap. Of course, we also find some kind of associated injuries. SL grade 3 was in 2 cases, 4 in 1, TFCC, those are foveal detachment in 2 cases. In fluoroscopy group, known associated injuries were found. In the arthrotomy group, because we could see the scapholunate ligament from the dorsal arthrotomy side, grade 3 rupture 3. And according to the protocol of this randomized trial, we did not address any of these associated injuries. So conclusion, as I said, the flexion is worst in the arthrotomy group. That's for us that we decide to don't do any arthrotomy anymore. Arthroscopy, yes, has the best intra-articular reduction. You can evaluate, assess the associated injuries, but it has, at 12 months, no clinical impact. Thank you very much.
Thank you very much. Any question from the audience? So, you have a question?
Yeah. Thank
Jeff?
you. I really enjoyed that. My question to you is the same as the last speaker. Now that you have this information, the next distal radius that comes in, will you put an arthroscope into that distal radius, or you just do it fluoroscopically and perhaps reserve the arthroscopy for something that's a little emotional and upsetting? What do you do?
You know, we love to do the arthroscopy.
Sorry?
We love to do the arthroscopy.
We all do, and
Yes.
this is a really big question. It's an ethical question.
Absolutely.
We're still learning. Where do you see us moving from this? Because this is wonderful information.
Absolutely.
How do we all leave and use this when we come from here?
Yeah.
Go from here.
I think that's the thing what we decide in our department. If we suspect some kind of additional injuries, you know, from the X-ray and from the CT scan, you already can imagine that this patient might have a scapholunate ligament rupture.
But we know that 90% have got scapholunate instability problems from the other one.
Absolutely.
They're dynamic. 90% have TFCs things. What do we do? Because I love putting a scope in, but
Yeah.
am I pushing the boundaries too far with this information you're giving me? Because I'm now trusting. I love putting a scope in. You see all sorts of things, but it appears not to make a difference. What do we do?
If you are honest, and if you look to the evidence, that's the way it is, yes. Arthroscopy has no benefit.
Thank you. What do you think about that, Philippe?
I think that if you lose time during an arthroscopy, which has no interest, why don't you use this time to preserve the pronator and make a small incision?
I have a question for Philippe. Tell me why you love the pronator. I know why I love it, but you've made a real emotional stand here, and it's a reasonable one, but why do you love the pronator so much?
Actually, I don't like the pronator itself. I like minimally invasive techniques. So when I preserve the pronator, the ligaments, the attachments of all the fragments with the ligamentotaxis, this makes the redaction easier.
With a smaller incision?
Yes.
Thank you. So we've got a reasonable question out here.
Thank you for your presentation. Now, you do the arthroscopy, but don't actually, no intervention is basically followed except for seeing the gaps and the steps in your reduction. Now, if you were to actually address all the pathologies that you end up finding, would you then expect a better outcome and consequently re-evaluate whether or not you should use arthroscopy?
No, we did the intra-articular fine-tuning. So we removed all the steps and the gaps in the arthroscopy group. But on the other side, if you be honest, if you have a grade 4 SL rupture and you reconstruct the radius, you have no dorsal inclination, you don't have a step in the scaphoid facet, I believe, I cannot show you, but I believe that even a grade 4 SL rupture, where the secondary stabilizers are still intact, will heal without any problems.
Thank you.
It's a very important question. What I perceived from this question was that if the TFCC is repaired and the scapholinate ligament dissociation or instability repaired, do you believe we may get a better result than the simple fluoroscopic reduction? Was that the question?
As the results are almost same, I don't think that we can improve our results.
But the question was, if you repair the TFCC and the scapholinate ligament in the arthroscopic group, do you think you'll get a better result than the simple fluoroscopic?
I don't think so, because we had no DRUJ instability.
Thank you.
In cases we didn't fix it.
Last very short question, please.
Very short.
Short answer.
So, I gather the risk scores were better at 12 months in the arthroscopic group. I don't understand why that's not clinically significant.
But you know, the risk scores are only numbers, and I don't know if that has a clinical impact.
Thank you very much.
I'd like to ask Dr. Jarbosa, I hope did I pronounce that properly?
No, it's Garbosa.
It sounds much better the way you say it. To talk to us about corrective osteotomy, assisted intra-articular with an out-in technique.
Good afternoon. Okay, the malunion occurs approximately in 23% of no-operative treat and in 11% of operative treat it's a radiofracture. The decision to correct malunion is related to the functional impairment and breast pain. Articular incongruity is an important predictor of the device functional outcome. From the literature, we know that intra-articular malunion presents with an intra-articular step or gap, which frequently leads to post-traumatic arthritis. Otherwise, there's no clear relationship between the radiological grading of the post-traumatic arthritis and the impairments in the patients. But in an overview of 50 dorsal radiofracture, we found that articular incongruity of 2 mm or greater were associated with a poor result. The indication is functional impairment, breast pain, articular incongruity with subluxation or radiocarpal joint, articular incongruity of more of 2 mm or 1 mm seconds of the outer. Contraindication is advanced arthritis and elderly patients. Three-dimensional reconstruction by CT could be useful for this technique. In the literature, we find 4 techniques: open, arthrotomy, experimental navigation, PSI, and arthroscopy. About experimental navigation, no experience. About PSI, I prefer this technique. for extra-articular osteotomy. The open technique provides to volar or dorsal or combined approach with a dorsal capsulotomy is necessary, but in this technique for exposing well the radiocarpal joint is necessary to create a damage of the capsula and create a damage of the ligaments. And otherwise, if we need to correct a volar malunion is too complicated with this technique without open the volar capsula. And the arthroscopy technique is very well described by Del Pignal. He used a shoulder periosteal elevator and a curved osteotomy. He suggests to realize this surgery as quickly as possible because it's not so easy to use this type of device. I try to use, but in my hand the space is not so big, and the other problem is when we use this type of periosteal elevator, we can create only 5, maximum 6 millimeter of osteotomy, and it's difficult after this to control the reduction of the fragment in my hand. I use only, the idea is to follow the original fracture line, and I prefer the dry arthroscopy for prevent the swelling of the soft tissue. It's possible to use sometimes before or after the plate, it depends on the case, and the portal is volar and dorsal portal. I realize an incision on a volar approach and a small dorsal approach without open the capsula. This is the first case, one male of 50 years old after 1 year of the trauma. This is the, sorry, no, I'm losing, I don't know where he is, why don't run? Okay, this is the CT image. Sorry. Okay, and this is the arthroscopic image with a screw inside the joint, and this is the gap inside the joint. I removed the callus exuberant. After this, if run, I remove the screw, I evaluate the gap, I realize with a K-wire the line of the fracture from dorsal to the joint. After this, sorry, don't run. Okay, sometimes I use a compass for help me in the correct position of the K-wire. I use a saw for cut the bone from dorsal, and a chisel for mobilize the fragment. After this, with a reduction with help of K-wire, in this case a reduction with a screw. This is the post-op result. This is the result after 1 year. This is a second case with a male of 16 years old, 15 months of the trauma. This is the post-op. This is the reduction with help of 2 K-wire. I have realized 9 cases in a mean age of 47 years old. Surgery at 10 to 30 months after trauma. In 3 cases are incorrect surgery. In 6 cases are after plaster result. 3 cases osteotomy of more of 3 fragments, and in 3 cases association with extra-articular osteotomy. The patient was evaluated with Gerton and Welly and Green and O'Brien system. There's no osteochondrosis of the fragments. This is the most important result on the pain. We have great degrees of the pain after 3 months, and with increase of range of motion in flexion extension of 65 degrees. In conclusion, the majority of the authors advise to promptly recognize the appropriate early treatment. Arthroscopy allows to preserve the ligament and articular capsula. Outside-inside technique seems to be more simple than inside-outside. It is very complicated to establish the role of the various components in a malunion, and the rotational problem is a not simple problem to resolve in this case. Thank you.
Thank you. Are there any questions from the floor? No? Nobody? Yes.
I like your incision. But why don't you preserve the pronator?
This could be an idea to preserve the pronators. For reality, of this surgery is necessary to maintain a short time of surgery, and I prefer to be very quickly when I arrive to put a plate and loosen time on this passage, but in the future could be an option.
Yeah, you know, because Paco demonstrated that it's possible to do this very difficult intra-articular fracture, to do it like minimally invasively.
Yeah.
So why don't we should push it for the plate also. Thank you very much.
Question?
Yes.
How much interval can we do the corrective osteotomy for the intra-articular fracture from the injury?
Sorry?
What interval?
How long?
The delay between the operation to the, for reality, because some patients arrive to me after 1 year of the fracture. In my area, there's no so simple, and arrived after a long time.
Okay, thank you. Thank you. This will be the last paper. The title is Arthroscopic Treatment of Chronic Wrist Pain After Distal Radius Fractures, which will be presented by Young-Gun Lee from Korea.
Thank you, Chairman. Good afternoon, ladies and gentlemen. I'm Young-Gun Lee from Korea. I'd like to talk about arthroscopic treatment of chronic wrist pain after distal radius fractures. Distal radius fractures account for about 15% of all fractures in adults, and therefore the treatment of these fractures is associated with a myriad of complications. Among them, the chronic wrist pain is common, and about 16% of patients continue to report the pain even 1 year following the injuries. Chronic wrist pain implicated the functional limitations of entire forearms and the emotional and psychological sufferings. So it should be treated, and acute delineation of the cause of the pain is the key for effective treatment, but the etiology has not been clearly understood. This arthroscopy has been used in the treatment of the intra-articular distal radius fractures, and soft tissue injuries have been found, and so that the prompt treatments have been performed, so we are able to get an increased functional result. But it is widely accepted by physicians, and previous publications were limited to the discussion of the operative treatment for certain specific conditions. Chronic pain arises from many complex causes, and we have to treat the complex pathoanatomy. And wrist arthroscopy is the gold standard diagnostic tools. So I performed the wrist arthroscopy for the patient with chronic wrist pain and did the tailored operative treatment according to the arthroscopy findings. So I want to report the arthroscopy findings and the result of operative treatment. From 2010 to 2015, we retrospectively reviewed the records of 11 patients, and the mean ages of patients was 49, and all had the unilateral involvement. The causes of injury was a slip down in, the most common causes of injury was a slip down in 8 cases, and initial treatment was performed at the hospital, but the wrist arthroscopy has not used for the initial treatment method, and the average time interval from injury to operation was about 14 months. Presenting symptoms include left-side wrist pain in 6 cases and generalized wrist pain in 5 cases. And wrist arthroscopy was performed as a usual manner. So first, we performed inspection on a radiocarpal joint, and we performed traumatic synovectomy in all patients. For the evaluation of the TFCC injury, we used the Palmer classifications, and for the evaluation of the intercarpal ligament injury, we used the Garcila's classifications. We also performed the additional operative procedures according to each arthroscopic findings, and We could find 4 patterns of pathological anatomy. The first was a TFCC injury, was seen in all 11 patients, and a traumatic injury was seen in 7 cases. And second, intercarpal and radiocarpal ligament injury was seen in 7 cases, and third was impaction syndrome was seen in 4 cases, and fourth was the chondral lesion and traumatic synovitis. 4 patients have combined injury of the TFCC, intercarpal, and the chondral lesions. Average follow was about 18 months, and average BAS score decreased, and the evaluation scores also improved at the final follow-ups, and there was no any complications. The etiology of the chronic wrist pain after distal lattice fractures is not an isolated problem, but multifactorial. So, in treating patients with these possible causes for pain in mind is crucial. The incidence of chronic wrist pain may be decreased because of the increasing use of arthroscopy, but still now, conservative treatment is accepted as the main treatment method, and wrist arthroscopy is not performed in all patients because of variable factors such as invasiveness, cost, and lack of skills. Therefore, we stress that the early accurate diagnosis with the wrist arthroscopy and proper surgical management according to the arthroscopy findings will give a good functional result for the patient with chronic wrist pain after distal lattice fractures. Thank you for your attention.
Thank you, Young-gun. Is there any questions or comments from the audience? I have one question to you, Young-gun. It's very interesting that most of your cases were treated by conservatively or cross reduction and pinning. What do you think is the difference? Now, in the era of the polar locking plates, although there is a soft tissue injury, it's very rare to have some problems after all. So what do you think?
My cases, 7 cases was conservative treatment method cases, and operative treatment cases are few. So I think the conservative treatment patient many pain causes than the operative treatment method.
Yeah. I have also a question for you. For me, arthroscopy is not a diagnosis tool anymore. So it's acceptable to propose an arthroscopy to patients in which you identified a pathology before. But here, I feel a little bit uncomfortable. Do you think it's really ethically acceptable to propose an operation to a patient even if you don't know exactly what is the problem? I mean, because if the MRI is normal, the CT scan with injection is normal, the bone scan is normal, so you say it's not very invasive. Yes, but sometimes you can get a complication with an arthroscopy, like CRPS or an infection or whatever. So what do you say to your patient if you have such a complication?
I haven't known any surgical complications, and but for the scapholunate intercarpal ligament injuries, for the evaluations, I think the arthroscope is more important and useful than any other method.
So what you're saying is if you have a problem and you have pain and you don't know what's going on, you can get important information using arthroscopy in the correct indication. Is that what you're saying?
Yeah.
Thank you. Look, this has been a fascinating session. As surgeons, I mean, I don't know what you all think, but when we put a scope into a wrist and you see scapholunate instability you didn't know was there, you see a floating triangular fibre cartilage which is grossly loose, you see steps in the articular cartilage, and we've all heard now that perhaps there's no need for arthroscopy. So we're still learning. We're out on the edge, and I would encourage all of you to come back the next meeting with longer studies, more information, so that we can solve this problem. Thank you to all the speakers.